Welcome to This Explainer. Today we're building a comprehensive blueprint for modern heart failure management. We're going to look closely at the latest clinical paradigms that are completely reshaping how we understand and, honestly, how we treat this condition. So if you want to know how the best current science is organizing patient care to drastically improve real-world clinical outcomes, you are in exactly the right place. Let's get into it. All right, let's jump right in by resetting our perspective for a second. For a long time, the old approach to treating heart failure was pretty much just about putting out fires, right? It was focused merely on alleviating symptoms so the patient felt better in the moment. But the new approach, it represents a fundamental, groundbreaking shift. We are now laser-focused on disease-modifying therapy. The goal isn't just to make the patient feel better today. It's to actively improve cardiac structure, boost heart function, and ultimately significantly reduce mortality. We're literally fundamentally changing the trajectory of the disease. So here is our architectural blueprint for today. 1. Modern heart failure paradigms. 2. The 4 foundational therapies. 3. Managing heart failure comorbidities. And 4. Acute care and interventions. Section 1. Modern heart failure paradigms. Defining the clinical phenotype. You know, we really can't build a strong treatment house without knowing exactly what kind of ground we're building on. The absolute crucial point here is that left ventricular ejection fraction, or LVEF, is the defining metric that dictates our entire therapeutic strategy. Today's management strategies are highly individualized. They are absolutely no longer one-size-fits-all. They're guided by the patient's specific clinical phenotype, and LVEF is the anchor of that phenotype. When we look at the spectrum of heart failure we're dealing with, we separate patients into 3 main phenotypes based on their LVEF range. You've got HFEF, which is heart failure with reduced ejection fraction at 40% or below. Then you have HFMREF, mildly reduced, hitting between 41 and 49%. And finally, HFpEF, preserved ejection fraction at 50% or above. Now, notice how our primary focus completely changes based on that single number. If it's reduced, we go all in on disease-modifying therapy. If it's mildly reduced or preserved, the focus shifts heavily towards symptom relief and managing comorbidities. That brings us perfectly to our first major focus area in Section 2, the 4 foundational therapies, the pillars of guideline-directed medical therapy, or GDMT. If your patient is in that HFrF category with an ejection fraction of 40% or less, these 4 pillars are the absolute non-negotiable foundation of their care. Pouring our very first pillar, we have RAS inhibition. Historically, sure, we used ACE inhibitors or ARBs here, but look at what the modern guidelines are telling us now. Agents like ARNIs, angiotensin receptor neprilysin inhibitors, have completely taken the spotlight. Why? Because they've shown definitively superior outcomes compared to ACE inhibitors alone. They're just flat out better at keeping patients out of the hospital and actively reducing cardiovascular death. This is disease modification in action.
Let's move over to the second pillar, beta blockers. But we aren't just throwing any beta blocker at the wall to see what sticks, right? We're using very specific, heavily evidence-backed agents like carvedilol, bisoprolol, and metoprolol succinate. These agents act as a vital shield. In heart failure, the sympathetic nervous system just goes into absolute overdrive, which is toxic to the heart over time. These specific beta blockers antagonize that nervous system response, protecting the cardiac tissue and letting the heart function way more efficiently.
Our third pillar involves MRAs, or mineral corticosteroid receptor antagonists. We're talking about medications like spironolactone or eplerenone. These are absolutely vital additions, especially for patients who are still fighting persistent symptoms. By blocking the harmful effects of aldosterone, MRAs step in to further drive down both morbidity and mortality. They really solidify the structural integrity of our treatment plan.
And completing our 4-pillar foundation are the SGLT2 inhibitors. Now, this is fascinating. These agents, like dapagliflozin and empagliflozin, were originally developed for diabetes, but they've emerged as a true game changer in heart failure. They significantly reduce the risk of worsening heart failure, and here is the amazing part. They do this regardless of whether the patient actually has diabetes or not. It's incredible, and they've well and truly earned their place as a foundational therapy for HFrEF.
Now, it's crucial to understand how we handle the extras outside those 4 pillars. Take diuretics, for example. They are absolutely essential for managing volume overload and congestion. You literally need them so the patient can breathe. But crucially, they do not have a proven mortality benefit. They don't rebuild the house, they just pump the water out of the basement.
For actual targeted therapies, we look to agents like hydralazine and isosorbide dinitrate, which are particularly effective for self-identifying African American patients or those who just can't tolerate RAS inhibitors. We've got ivabradine to specifically dial down a resting heart rate that is 70 beats per minute or higher in sinus rhythm. And finally, digoxin is kept in reserve for those patients who still have persistent symptoms despite being on optimal 4-pillar GDMT.
Section 3. Managing heart failure comorbidities, addressing the whole patient in HFpEF and HFmrEF. Now that the foundation is poured for HFrEF, what about the rest of the house? The strategy completely shifts for patients with preserved or mildly reduced ejection fractions, making this our second major focus today.
Here is a huge pivot in our clinical strategy. When a patient has an ejection fraction of 40% or below, we obsess over those 4 pillars. But as that ejection fraction rises above 40% into the mildly reduced or preserved categories, the clinical trials become less definitive regarding those traditional pillars. While things like SGLT2 inhibitors still show benefit across the full spectrum, our primary overarching strategy moves heavily towards symptom relief and the aggressive control of underlying comorbidities. Essentially, we are treating the neighborhood surrounding the heart.
To treat the whole patient in these higher ejection fraction categories, we have to pair specific issues with highly targeted interventions. If the patient has obesity driving their heart failure symptoms, we look at GLP-1 agonists. If they have iron deficiency, which, by the way, is incredibly common and debilitating in heart failure, we don't just tell them to eat spinach, we use intravenous iron, like ferric carboxymaltose. We aggressively control hypertension. We use targeted sleep therapy for sleep apnea. The overarching philosophy here is that by aggressively managing the comorbidities, we reduce the strain on a heart that's actually pumping relatively well, but is stiff and filling poorly.
Section 4. Acute care and interventions, the fallbacks for decompensation and advanced disease. Because we have to ask, what happens when the structure is actively threatened?
When acute decompensation hits, when the patient actually crashes, we follow a very clear stepwise escalation tailored to their specific hemodynamic profile. Step 1 is always volume management. We aggressively use intravenous loop diuretics like furosemide. If they're resistant to that, we might even use ultrafiltration to physically pull the fluid off. If that's not enough, we move to Step 2, vasoactive therapy. We use vasodilators like nitroglycerin to rapidly relieve pulmonary congestion, or if their output is dangerously low, we use inotropes like dobutamine to force the heart to pump harder. And Step 3, our ultimate fallback for refractory cardiogenic shock, is mechanical support, relying on hardware like an intra-aortic balloon pump or ventricular assist devices just to keep the blood flowing.
Beyond the acute phase, we turn to long-term structural support. We often rely on specific hardware and surgical interventions, meticulously matching the device to the patient's specific deficit. If their LVEF is 35% or less, they're at high risk for sudden cardiac death, so we implant an ICD for primary prevention. If they have HFrEF combined with an electrical coordination problem, specifically a wide QRS like a left bundle branch block, we use cardiac resynchronization therapy, or CRT, to get those ventricles contracting together again. We look at coronary artery bypass grafting, or CABG, for ischemic issues, and minimally invasive options like transcatheter mitral valve repair, or TMVR, for symptomatic secondary mitral regurgitation. It is literally precision engineering for the human heart.
But you know what? All of this incredible technology and pharmacology means absolutely nothing if we drop the ball when the patient goes home. The care simply doesn't stop at discharge. Effective high-quality heart failure management mandates comprehensive transitional care. That means early follow-up within 2 weeks. Why so soon? Because we have to safely up-titrate those foundational GDMT medications we talked about earlier to reach their maximum effective doses. And just as importantly, it means having the courage and compassion to initiate palliative care discussions and prioritize end-of-life preferences when the disease reaches advanced, refractory stages.
So, as we step back and look at this incredible blueprint we've walked through today, from the 4 foundational pillars completely reshaping HFEF to the aggressive whole-patient comorbidity management in HFpEF, we are looking at highly individualized, phenotype-driven therapies. With treatments now so exquisitely tailored to specific ejection fractions and exact comorbidities, we really have to ask ourselves, have we finally moved past just managing heart failure and entered the era of truly personalized heart failure survival? Definitely something to think about as you apply these paradigms. Thanks for joining me on this explainer.